Hello, my name is Leon Scott. I'm one of the faculty members with Vanderbilt's Department of Orthopedics. I am going to be replaying this talk that I gave to residents that discusses contributions to racial disparities in healthcare and opportunities that we all have in the healthcare field to change them. So as I go through, we will be, no financial disclosures, going over the healthcare disparity evidence, specifically looking at orthopedics, and sharing my opinion on the root cause for those disparities, as well as the historical information that supports that opinion. Instead of stopping there, I'm hoping that we can create a framework together that we can all use as a scaffold for building useful solutions that can be effectively implemented. This talk is going to focus on the Black and white racial examples when talking about healthcare disparities. There are going to be some similarities with other minority groups and with gender groups, but for a more detailed look at those situations, I think another set of talks would be appropriate. So within orthopedics, we've noticed over the past 25 years that there have been disparities in healthcare outcomes and utilization. These have been documented in examples shown here. They include differences in outpatient orthopedic utilization, outpatient surgical care, and even the utilization of surgical care in orthopedic traumas. Now, when looking for reasons why these disparities exist, the discussions of these papers always admit that they are limited in their ability to say why things are occurring, just that they are. And it's not a big surprise because they're all level of evidence 3, retrospective, typically retrospective cohorts studies. And very few of them are multivariate analysis, meaning very few are looking for independent variables that play a role. But when they do, in the discussions talk about what the potential reasons are for these disparities, intrinsic factors, extrinsic factors, and systemic factors are often discussed. Now, if we're going to look at intrinsic factors like DNA or protein expression, I caution everyone before going down that road. Those arguments tend to age poorly. They didn't age well for social Darwinism or phrenology or anthropomorphic measurements used in actuarial data. So be cautious. When looking at extrinsic factors like cultural preferences or physician bias, I think this is those are issues that definitely play a role in episodes of healthcare disparities. But for me, it may not be the lowest hanging fruit, or at least perhaps not the way to create the largest change. So yes, take classes on cultural competency, but there may be more effective levers to pull. When looking at systemic issues, looking at the healthcare system, transportation, housing, the financial system. By making one change here, we could have a big change on a lot of people's healthcare experiences. But when these are discussed, very frequently, I think the root causes that they allude to are a bit superficial. Looking at education or access to healthcare insurance, to me, just doesn't seem to cut it. When I look at things historically, what stands out is one root cause, and that is segregation. Segregation is the defining feature of racial inequality in this country. Now, before moving forward, I want to make sure that we're working with the same definition. Segregation is when two equal parts of a whole are separated, and that separation is designed to give the separator an advantage over the separated. When an organization has its domestic workers primarily represented by African Americans, but there has not been one surgical faculty member in its Department of Orthopedics, That is a result of the designs of segregation. Segregation erodes respect. Segregation limits opportunities, and it has created a wealth gap. For this talk, I am not going to dive into the erosion of respect and how to re-establish respect. I am not an expert in that field. I do think there could be a lot of benefit if people were to read books like Nonviolent Communication by Marshall Rosenberg and other similar books, but I'm going to have to leave that to another expert for another talk. I will be talking about limited opportunities, specifically limited opportunities for healthcare providers, the limited opportunities for Black providers to move into healthcare, especially subspecialties services like orthopedics. And we'll be talking about the wealth gap as it has been identified by healthcare economists like Uwe Reinhardt. Groups that have lower wealth tend to utilize healthcare less frequently, and that may and does contribute to the healthcare disparities that we see. So how can we affect the wealth care gap or the wealth gap? And talking about the wealth gap, I want us to actually think about Blacks in America as a single enterprise, a single business, if you will. We're going to talk about wealth and money, so let's talk about it like a business. And it may be helpful to use a framework of financial statements. Now, if you're in healthcare and you may not really understand financial statements, every business uses this to help assess and describe their financial health. So the Black enterprise's income, its total revenues, total income would be the top line. That's on that top left here, okay? Then when you subtract the expenses and taxes, you're left with net income, a group's net income. Oftentimes we call that profit. Now, profit isn't actually the amount of spending power you have. So we take that net income, take it up to the cash flow statement in this very simplified version of a cash flow statement. That net income minus the amount that's used for investing in properties or upkeep of capital investments. Once you subtract that and add in or subtract the amount of spending power you have from financing. Do you have lines of credit available to you? Or do you owe creditors? The sum and result of all of that is the change in available cash or spending power over a period of time. Now, from the beginning of time until now, all that accrued would be the cash on hand or your current assets in hand. That's the money I have in the bank. That plus the things that I have, my assets, real estate, stocks, goods, bonds, minus the amount that I owe to others, the liabilities, leaves me with my equity. It leaves me with what I own. That is my wealth. So that's our definition of wealth. When we look throughout history, the Black enterprise, Blacks' wealth in this country has been altered over the same period of time and created two divergent wealth groups. And for the purposes of this talk, white and Black. So starting in 1866, many Southern states began implementing laws that limited the opportunities for work. Farmer or domestic worker, if you want to do anything else, you had to get annual licenses and approvals to do so. That loss in job opportunity is a loss in income. That affects my eventual wealth. Then 1866, General Sherman signed Field Order 15, providing 440,000 acres of land from Charleston, South Carolina to Jacksonville for Blacks to own. That is that was the establishment of real estate that adds to Black wealth. Less than a year later, President Andrew Johnson, 1867, pardoned the Confederacy and returned that land back to white Southerners. That is a loss in wealth. Now you may be saying, well, that land wasn't really yours to begin with. So if it was taken back, I guess it doesn't make that big of a difference, right? But in comparison, in 1867, when 440,000 acres was removed from Black ownership, then that same year, 1.3 million acres was provided to private enterprise, and between 2 and 4.6 acres was provided by the federal government and granted to white Americans. So in that year, there is a disproportionate allowance and granting of land between groups, with Blacks having their land removed. Still, during those hardships, Blacks in America were working hard and encouraged to save, especially in a bank called the Freedmen's Bank. At its peak, $75 million was saved, or the equivalent to today of $75 million was saved in deposits in that bank. Unfortunately, the charter for that bank changed, and the all-white board of that bank was allowed to begin investing the depositors' money. And unfortunately, it lost it in the first post-Civil War asset bubble. And that $75 million was diminished to $3 million. The doors were then closed, that money reported not to be returned to the depositors. And the day those doors closed, it's estimated that 50% of Black wealth was lost. Cash and current assets on hand lost is a loss in wealth. Still, there were groups of Blacks that would form together, different towns, and enclaves of success began to pop up around the country. This may have angered individuals, and unfortunately, many massacres occurred in these towns, including Wilmington, North Carolina, 1898, Rosewood, Florida, 1928, and Greenwood, Tulsa, Oklahoma, in 1921, where it's estimated that 5% of the Black residents were massacred, the rest were moved off of their land. A loss of land is a loss of wealth. The money in their banks was removed. That loss of cash and current assets is a loss in wealth. The companies and jobs that they held, gone. That loss of income is a loss of wealth. In 1913, Southern farmers were unfortunately not able to access credit and participate in the global economy, as Northern bankers were controlling the money supply. Woodrow Wilson in 1913 created the Federal Reserve, helping to relinquish power of the money supply and move it more centrally and away from private bankers. In 1916, Woodrow Wilson also signed the Federal Farm Loan Act, so that credit could be extended more easily to Southern farmers and improving the economic standing of farmers in those Southern states. That was extended to white farmers, not to Black farmers. A loss of financing opportunity and the productive work that would follow, unfortunately, diminishes wealth opportunity. In 1934, the New Deal from FDR was signed. So many components to this, but for this discussion, we're going to focus on the FDIC, ensuring bank deposits, the FHA, allowing for federally backed and insured mortgages, and then the Federal National Mortgage Association, Fannie Mae, which created secondary markets. So around the globe, people could invest in bonds that were backed by American mortgages, increasing the economic activity in this country. Unfortunately, those home loans, the opportunity to buy land and property was not extended to Blacks in America, as these opportunities were managed on a state level, which is often code for local administrators are able to administer loans at their own discretion, establishing their own reasons for denying a loan request, frequently because of race. Unfortunately, to protect the national investment, redlining and covenants were allowed, which legally separated Blacks and diminished the value of their property. But beyond just this loss of financing opportunity and this loss of property, things that would affect wealth positively, there is also the nasty effect of increase in expenses for Blacks relative to whites. What happens when you cram a group of people into a place with limited apartment housing? When you have a lot of demand and limited supply, the price goes up. The price of living in these ghettos was relatively more expensive than the price of living elsewhere. Increasing expenses further diminishing the opportunity to develop wealth. The GI Bill in 1947 extended many of the same home ownership opportunities to veterans as they returned from World War II. Unfortunately, also administered on the local level, there was a limitation in the number of Black soldiers and veterans that were given access to the supports from the GI Bill, especially the housing components of it. Specific examples: 16 million veterans from World War II, American veterans from World War II, 7%, 1.2 million of which were Black. When applying for home loans in Mississippi, 3,200 requests in 1947, only two of which were granted to African Americans. In New York State, not New York City, sorry, New York State, 67,000 GI Bill-backed mortgages provided, only 100 of which went to Black veterans. Another little curious note in history: in 1974, the Equal Credit Opportunity Act made it illegal to include questions about race or gender on credit card applications. This occurred primarily because affluent women were finding it difficult to gain access to credit cards and wanted to have this changed. So that was changed. The limitation in access to financing, again, limits the opportunity to do productive work because you don't have the ability to finance productive enterprise like starting a business. That diminishes the opportunity for creating wealth. From 1865 to 1965, these historical events created a divergent wealth group between white and Blacks in America. Since 1965, there are some reports that say the percentage growth in wealth has been fairly similar since that time. And that is encouraging to a certain degree. But when we look at the absolute numbers, we actually see that there's still a divergence. Because if someone starts with 10 of something and someone else starts with 2, and both have a 50% increase over a period of time, those slopes are different. 10 goes to 15, 2 goes to 3. Similar percentage change, 50% increases, different absolute changes. The wealth gap continues to grow. So if we're going to find ways for your healthcare organization to affect the wealth gap, and the purpose of doing that is to help increase wealth for underrepresented groups, Black Americans, so that they can use their wealth like other individuals who are wealthy do to access and use healthcare and do all things in America more readily. There are some things that you may want to consider. And when considering them, think about the financial statement. Anything with a plus sign, you can do more of it. Anything with a red minus sign, you can try and do less of it. And you can try and do this by looking at either racial groups, trying to make sure that proportions are equitable, or in situations where that is viewed as favoritism, you can try and make some of these changes so that they affect certain zip codes. For income, if you want to increase the income of the Black enterprise in your healthcare organization, take a look at your vendors. Are the vendors that you choose from for catering, for supplies, the individuals and institutions that do your banking, are they equally and equitably represented when you make your selections? 13% of America is Black. Are 13% of your catering companies Black owned? Is 13% of your organization's banking done through Black owned banks? When looking at expenses to try and decrease the expenses for the Black community, there are some really creative approaches that have been taken on by Geisinger and Kaiser, where they have included transportation, housing, food, into their healthcare plans. So yes, they are unique in that those organizations are owned are also insurance companies as well as healthcare companies. So they are both the payer and the buyer. But your organization may be able to do some creative thinking and in providing many of these expenses as part, or covering some of these expenses as part of the treatment plan. When looking at financing to create credit opportunities, you could extend favorable terms to individuals that live in certain zip codes, but even perhaps more effective, going back to the idea of banking, if you are both depositing your organization, depositing into Black-owned banks, and also taking loans from Black-owned banks, that allows for a cycle, a magic trick that banks use called fractional reserve banking to increase the money supply for a community. So that's something to consider as well. And then an idea that I thought was really clever that I heard once is that for individuals who use public housing, the public housing, hold on one second. There we are. To increase wealth in real estate for some of these groups, perhaps another Homestead Act where public housing can be granted to underrepresented minorities or other groups that live within those public homes so that they can have a property with an assessed value against which they can take out lines of credit for creating their own businesses. So those are some ideas. Now, if you're an institution that is not a not-for-profit, then there may be an opportunity for your local government to create incentives, tax incentives for institutions that utilize these type of ideas to reduce the wealth gap and increase, therefore, the opportunity for individuals to participate in all the services that a community has, including healthcare services. Now, jumping over to limited opportunities and addressing the limited how segregation limits opportunities for Black future professionals who want to move into the healthcare space. Specifically focusing on orthopedics and orthopedic surgeons, of the active orthopedic surgeons in the country, only 1.9% are Black. The residents that will become orthopedic surgeons currently make up, Black residents make up 4% of the resident pool in this country. And that number, although greater than 1.9%, has not changed much in the last 10 years. The number of applicants for these positions is higher than 4%, it's 10%. So 10% of the applicants for orthopedic residency positions are Black. There's some reasons why the percentage of applicants and the percentage of those that are that receive positions may be lower. Objectively, one of those reasons is that the STEP scores, this is the testing that's done, the step 1 and step 2 tests are represented in gold and blue, but those standardized tests, Black students perform on average lower on those standardized tests compared to other groups. From left to right, these bars represent white, Asian, Black, Hispanic, and other racial groups. But despite the fact that this objective measurement seems lower, there are some other measures that seem to be higher, like the amount of volunteer time that students are involved in. Black students involved in a significantly higher amount of volunteer efforts than other racial groups. For the students that do meet all of the criteria, objective and other more subjective criteria, it still may not be of interest to go into orthopedics. If we look at all underrepresented minorities, Black, Hispanic, and Native American, that is about 30% of the country. Yet, when we look at the orthopedic programs around the country, this chart shows us that faculty members in gold and residents in blue, that there is a peak to the percentage of individuals that are not underrepresented minorities, or there is a peak where the percentage of individuals that are underrepresented minorities is far under that 30% national number. So in a orthopedic residency where there may be somewhere between 10 or 20 residents, if there is 5 to 10% representation by underrepresented minorities, that unfortunately may only be 1 to 2 individuals, and that can be a very lonely experience. So perhaps that is deterring people from going into orthopedics. Evidence that further supports this is that although 10% of applicants are Black, the country is made up of 13% of Black citizens. So there might be a disinterest in even considering orthopedics. To address these issues, the limitations on opportunities to go into rewarding fields like orthopedics, there are some things that you may want to consider. 1, try to increase the competitive pool. 2, attract candidates from the pool that already exists. And then 3, until the time where we can start to make some major numeric changes that better represent our country as it is currently constituted, we can try to assert influence in other areas. So to increase the competitive pool, one thing that organizations can do is get involved with groups like the Perry Initiative or Nth Dimension programs. These are programs that take, respectively, high school girls or first-year med student Black students and expose them to science, engineering, or specifically orthopedic services, so that their interest in those can increase. Now, it might be selection bias, where people who want to go into orthopedics are signing up for Nth Dimension, but Nth Dimension has a much higher matriculation rate with individuals who go through their programs becoming and finishing as practicing orthopedic surgeons. From the current pool of Black physicians, again, Black orthopedic surgeons, 1.9% of that group, if you're looking for new faculty to fill faculty positions, you got to know where they are. So if people are asked, as is often the case, to reach out to your friends and your peers and your colleagues to see if anyone's interested to joining our institution, you may not know anyone diverse. So going to groups like the James Robert Gladden Orthopedic Society and seeing how you can engage them so that this pool of Black orthopedic surgeons can be marketed to specifically would be an excellent strategy. I believe the Ruth Johnson Orthopedic Society is a similar group for women orthopedic surgeons. But until the time when you create a pool of students that then become residents and then become faculty, or pulling from a smaller pool of current orthopedic surgeons, until that time when you can do that successfully, you can also try to assert your influence to create a diverse environment where you work. For example, you can, when evaluating vendors for different medical supplies or surgical instruments, you could say, we want to make sure that you have high quality product, that you also value safety. Of course, all of these things. But in addition, we want to make sure that your workforce is diverse, not just the reps, but the managers and the leadership. And we want to see those numbers in your proposal for the purchase of your equipment. And if you do not meet our criteria in all those areas, quality, safety, price, and diversity of the individuals in your organization, then you're going to be considered after other individuals that meet those criteria more adequately. We could also do the same in schools of medicine. We could say at a major institution, if you want your students to do clerkships, fourth year away rotations here, then we need to see that your admissions, your staff, your faculty are growing in diversity the way that we see this country constituted. And if we see that, then we will more openly consider the applications from your student body. We could encourage vendors to financially support increasing the pool of competitive candidates. I believe a study from McKinsey said that there's $66 billion since the George Floyd murders, $66 billion pledged by corporations to help reduce and eliminate racial inequality. If groups like Arthrex and Stryker or Medtronic, if they are in this group that has pulled money aside, instead of using it in ways that are not focused, they could potentially focus it into this into these groups, because that would have a direct impact on the main problem we're trying to solve, the limitation in opportunities. Groups could hold the orthopedic and medical centers accountable. Groups like the Gladden Orthopedic Society could say, hey, if you're going to use our marketing materials and reach out to our members, we need to see from you, Vanderbilt, that individuals who are hired are also being considered for promotion, that their research is being promoted, that their access to grant funds is equally available. And then for the, especially addressing the standardized testing issue, a creative idea could be groups like USMLE, the organization that oversees and administers those standardized tests. They know that there are a dozen organizations that use their test questions, that pay for their test pool in order to create the test prep programs. They could say, well, we want to see that your marketing is your marketing dollars and your marketing efforts are spread equally and equitably across all groups, so that Black students and white and Asian students are all having equal opportunity to be exposed to marketing to use your test prep services. And if you don't, then we'll give you old questions from 10 years ago, and we'll save our most recent used questions for the groups that we see are meeting our thresholds and criteria. And perhaps that change in marketing or strategies similar to that could have an effect in addressing some of the objective differences seen between groups. So hopefully, this has given you a framework to think about how to improve or eliminate the wealth gap, so that all individuals, all Black citizens of this country can have a more equitable opportunity to build wealth, and then to access healthcare and utilize it in a way that eliminates these disparities. And for opportunities to develop as a healthcare professional, hopefully these brainstormed ideas and frameworks are helpful as you and your organization try to create opportunities for your students and future residents. But no matter what, I do hope that you'll reach out to me. My handle for Twitter is there, Leon Scott MD. Well, hopefully you will reach out so that we can group and create concerted efforts instead of pockets that are doing one-off ideas that are floundering. We can have more of a community approach. So I hope this was helpful. I appreciate any feedback and that you can provide. Special acknowledgement to a few authors that help provide information here. Mirza Baradin, who wrote The Color of Money, and Shamari Wills, the author of Black Fortunes, for some of the historical context. Just amazing books for individuals to read, pick up and read. And again, thank you. Good night.